this responsibility today to deliver this talk on PCI and multivessel disease in CAD, outcome according to the coronary lesion complexity. We all understand that if we have a three-vessel disease or multivessel disease in a given patient, we have to evaluate the risk involved, the complexity of the lesion and the risk involved. So we have learned a lot about the syntax score, which is beautiful, which gives you correct idea about the anatomic score. But now syntax score is not syntax score alone. Now syntax score 1 we are talking of, only anatomic. Now there is syntax 2 score, which takes into consideration the comorbidity. Now third syntax score takes into consideration comorbidity, anatomic as syntax score, and also in addition functional evaluation. So all this we have to now note, and of course the revolution study has revealed another syntax score which is different from functional evaluation, but which is non-invasive, CTFFI. So only syntax score is not enough to evaluate. We have learned through the syntax trial that only syntax score is not completely reliable to understand the risk involved in the lesion. So we need to look at CHIP score as well, because CHIP score takes into consideration the patient factors, the procedural factor, and you will note that every rise in CHIP score by 1 point, when CHIP score is 0, the MACI is 1.7%. But as soon as it becomes 5, it becomes 12%. So CHIP score becomes very important to remember to understand the severity and risk of given procedure. And this is what it is saying, that as the CHIP score rises, the MACI rises. For every 1% increase in CHIP score, 1 increase in CHIP score, the MACI rises by 28%. Now, many multivessel disease also have CTO. So we need to take into consideration J-CTO score, because J-CTO score will tell us the success rate. Earlier, the lower the J-CTO score, success rate is higher of successful CTO crossing and angioplasty. Now, syntax 2 score has revealed, when it is compared with CTO in syntax 1 and syntax 2, syntax 2 has 87% success rate, whereas 53% in syntax 1. So it's a remarkable difference because of understanding of the entire subset in a proper perspective. Now coming to how do we judge all this, or physiology do play important role. In syntax 2 2020, there was no physiology assessment. So CABG looks better. But after you have a physiologic assessment, the CABG PCI becomes equally good. Similarly, we have learned from the IVI trials that imaging, intravascular imaging, does play a very important role in giving good outcome results. And calcium is another aspect that puts multivessel disease, PCI, in a bad light. So we have now various tools which we can optimize the calcium or modify the calcium so that stent expansion is normal, that reduces the miss rate. Then, of course, very important aspect is those patients who have low EF, less than 35% or 30%, and have very complex lesion, they should get the hemodynamic support, what we call a PROTECT PCI. And it has been shown by the study, a real-world study of 4,351 patients, and the follow-up suggested that protected PCI was in 2,700 and 1,500 an unprotected PCI. And you can see the cumulative event rate is significantly lower in a protect PCI arm, which is p-value of 0.001, very highly significantly better. Now we have various protect PCI hemodynamic support devices, and we all know that from what we use IABP, now Impella is also available, tandem heart, ECMO, all these are available to us. The cost is prohibitive, but now there is a new device which has come, hemodynamic support, which is called as ECP, expanded cardiac power. So Impella CP, now Impella ECP. What is the advantage? It is 9 French, but can pass through 7 French sheath and can be closed by angiosyl with the success rate of 92%. So this becomes handy for use in patients who require really hemodynamic support and have a low EF and good reserve. Then there is improvement in the stent. In the syntax core, generation 1 stent was used, but now we have 3 generations of stents which are highly well developed and which matters in terms of long-term outcome. So we are talking of multivessel disease, long-term outcome in the current era. And we know that the bioabsorbable polymer-coated stents are now available, and there are several varieties of it, from first generation to second generation. And now we have a third generation. We know that Synergy is the third generation stent. Syntax Core 1, we have a syntax trial which is over a period of 10 years, and it evaluated low syntax core, intermediate, and high syntax core. We can see that the CABG and PCI, when compared with intermediate and high, PCI looks very weak. But if it is in low syntax core, it's almost clinically insignificant, though numerically little more in PCI arm. But in last 1 decade, we have improved the drug-eluting stent. The struts have become thinner. We evaluate physiology. We do IVI in many patients. And CTO success rate has gone up because of the development of the skill and various other devices which we use during CTO operation. So we should have one more study comparing the result of current state-of-art devices that we have. And this is multicentric study done in without a left main setting, using syntax 2 score, about 450 patients. And this is very important to get an optimal result in any multivessel disease. We evaluate appropriate lesion selection should be appropriate. Most appropriate DS should be used, like if you're putting it in a proximal LAD which is calcified, and you think that it will require higher strength to expand completely, then we can use Megatron, which is providing a higher strength. Optimal stent and use IVI to optimally deploy the stent so that long-term results are good. So in syntax 2 trial strategy, in addition to using syntax 2 score, we are doing IFR, we are doing IVI, and deploying new generation stents. And CTO, as I said, has improved overall due to skill development and also the device development. And impact of coronary physiology, you can see that if you apply coronary physiology, only 2.64% patient will require stent, whereas 402 in syntax 1. So lesion assessment becomes very vital, and this is significantly different from what it was in earlier. Similarly, 3-vessel disease, 83.3% in syntax 1 and 37.2% in syntax 2. Now, IVI use in syntax 4.8%, syntax 2 84% was IVI used. Then CTO crossing 87% success rate as against 53% in syntax 1. All this will definitely impact the long-term outcome result. Looking at the physiology, it is very important that we assess the physiology as we have discussed, and this is what physiology will tell in summary. So using all these 3-year result comparing syntax 1 versus syntax 2, and you can see the cumulative event rate MACI is significantly lower in syntax 2 using all the adjunctive devices like physiology, IVI, and latest generation stents. So looking at all these parameters, it's very important that we understand how syntax 2 has reduced overall the MI and also the death rate in patients where syntax 2 score and using all this technology. Similarly, MI, you can see thrombosis rate also is less than 1%. In addition, if you use 2 stent versus 1 stent in a patient who's got also a bifurcation lesion in multivessel disease, clearly the new generation stents are far better. And doing complete revascularization provide 0% residual syntax score, excellent 0% death rate. But as the syntax score, residual syntax score increases to 10%, the also death rate increases significantly. Similarly, if you see the benefit of complete revascularization from the complete trial, it's clearly stating that if you have 3 years follow-up, you can see that p-value is highly significant in complete revascularization arm as compared to incomplete revascularization. EF also improves considerably. So in summary, goal is complete revascularization using latest adjunctive devices like IVI, physiology, latest generation stent, and if necessary, hemodynamic support using the latest impeller device or any other that is suitable at that time. Thank you very much for kind attention.